Hi everyone, I'm Dr. Heather Hirsch and welcome to my YouTube channel, Health by Heather Hirsch. Today I want to discuss something that you probably will encounter at some point in your gynecologic history, and that is why to get a pelvic ultrasound. They kind of sound a little interesting and looming, especially if you're not having a baby. Certainly that makes the most sense. They're checking on the baby. But why else? What is it that your doctor is looking for? How can you know what your ultrasound means? I'm going to break it all down for you in this video. If you guys don't already know, before we get started, you can follow me on @hormone.health.doc on Instagram. And I'm also on Twitter at HeatherHirschMD. And lots of other things. I have my own podcast, Women's Health by Heather Hirsch. I will link that in the description bar below. And there we talk about all things women's health, whereas on this top channel, we talk mostly about midlife and menopause. And you can also check out my course, The Complete Guide to Menopause. You can find it in the link below. It's wonderful. Of course, I'm biased, but it's really a phenomenal education. And you can also check it out and other things on my website, heatherhirschmd.com. Awesome. All right, now that we've gotten all that out of the way, I just want to say I'm super excited to get back on a little bit more of a regular schedule, getting my videos out at least once a week, ideally on Fridays, now that my kids have gone back to daycare. It was really hard to get a quiet moment to film, and I still know every once in a while you might hear a car zipping by or my dog barking because I can't send her to daycare. Anyways, we are here to talk about why your doctor wants you to get an ultrasound at midlife or really any time after pregnancy. So, there's a couple big reasons I, as a menopause expert, tend to order an ultrasound. So I'm going to start with those. So one of the biggest things that happens when you are entering perimenopause, and you can break perimenopause down into early and late perimenopause, but the first thing that you'll notice is periods tend to become irregular. Now they can be either really light and spaced out, or for some women they can become really heavy and last longer. And at the same time, you might also be having big breaks in your periods. So you could kind of be having both, right? You could go every 3 months, you get a whopping period, and then maybe next month you get a whopping one, and then nothing for a few months, and on this goes. So that's when an ultrasound sometimes becomes another data point for your doctor to help you determine, first of all, if we can determine the underlying cause, and two, how we can best help you. So there's two big things we want to do. So one of the big things we just talked about is all this irregular bleeding or heavy bleeding. So there's a couple big etiologies or reasons that you could be having that, and then hence a reason why an ultrasound is helpful. The first is hormonal, and clearly when you're in perimenopause, your hormones are swinging erratically and sporadically, and that can lead to an incredibly irregular bleeding pattern, and that certainly can be one reason why. And I did another video, which I will link here above, on how to determine your labs, but certainly lab work can be helpful, and I always recommend you or clinicians ordering a TSH or a thyroid panel, an FSH level, and an estradiol level, and A1C, and certainly those labs can help determine, in this big scheme of things, if it's a hormonal reason. A lot of the times it is, but there's other things that we don't want to miss, which is anatomical causes, and that is where the ultrasound comes into play. So I'm going to put up a picture here of a uterus, and what are some of the anatomical reasons you could be bleeding? Well, you could have a polyp or a fibroid in your uterus, and essentially they are just increase in the surface area, increase in the layers of the tissue that is responding to those hormones, and they can certainly be making the situation worse. So you've got those erratic hormones and extra tissue, extra surface area in those polyps or fibroids, and knowing you have those can help determine how to manage you. The other thing that we tend to look for on an ultrasound is a uterine lining thickness. Now, why do we care about how thick your uterine lining is? Well, when you're into that late perimenopause, early menopause, we want to make sure that you are not having post-menopausal bleeding and that it's just being it's mimicking just erratic, perimenopausal bleeding, okay? And that is really important. It's certainly not the number one cause, but it is something that we do not ever want to miss for you. So the uterine lining is really helpful and being another data point for us to determine how best to evaluate you. So what's considered normal is when your uterine lining is under 4 millimeters, and if it's greater than 4 millimeters, we worry about it being a little bit on the thicker side. So let me sort of explain this in a way that maybe makes some kind of a sense. As those cells are sitting there, and they might build up and build up and build up, there's a chance that one of those cells goes haywire in that field, if you will, of cells of that cellular layer. And if so, that's when you can get precancers. You could get hyperplasia and metaplasia, which is a precursor to cells kind of going a little bit more haywire, and then precancerous and cancerous cells. So if that uterine lining is really thick, that does make us a little bit more nervous, and that might prompt us to do an endometrial biopsy. When you get an ultrasound, we're also going to evaluate those ovaries because the technician's probably going to take a peek at them, make sure there's no large cysts there, make sure that they're getting good blood flow, and etc. Another thing that sometimes can be seen on ultrasound, but not always, as it's maybe not the best modality, but certainly with a skilled technician and physician, sometimes endometriosis or adenomyosis, which are both conditions that can cause chronic pain or pain with menses, sometimes those can be evaluated as well. And we also sometimes may order an ultrasound if somebody is presenting with signs of polycystic ovarian syndrome, which is elevated androgens, again, and wonky periods. And in that case, we usually are honing in on the ovaries, looking to see if there's something called a string of pearls. It's where all the follicles line up. It's sort of just like it sounds, like a string of pearls in your ovaries. And so those are some of the big things that we are evaluating when looking at an ultrasound and understanding and using more data points with your labs and your imaging to decide how best to manage and what to do next. Now, a really clear case when we might want to do an endometrial biopsy is if somebody does get their labs and their FSH is high in the menopausal range, which is usually greater than 35. So let's say it comes back at 70, and someone has complained of periods and they're getting them once every 8 or 9 months, and that uterine lining comes back a little bit thickened, say 6.5 millimeters. I might certainly want to do a biopsy because that is the best way I'm going to know if that cellular layer has any type of precancerous or cancerous cells in them. Now, an endometrial biopsy is not always perfect because this is a procedure that's done in the office where your doctor does not have a camera in your uterus. They're just doing a procedure from looking at your cervix. And so certainly sometimes then women end up with having D&C or hysteroscopy with a D&C, and that's when you get put to sleep, or in actually some academic centers they now can do this in the office, but very few at this point. And there's a little camera that goes into the uterus so the doctor is not blind and they can see where some of that tissue is that they want to take and have the pathologist look at under the microscope. So we kind of want a couple of things. I've mentioned the lab work is really important, the imaging and the ultrasound is really important, and the third piece, which is so crucial, is journaling and tracking. I've really just started saying this so much, but you putting together your history of any type of bleeding or spotting or symptomatology that might be classic of low estrogen, i.e. menopause, like hot flashes, trouble sleeping, vaginal dryness, brain fog, what have you, certainly if you can track a lot of those, that's really going to help your clinician put this all together. So what about my patients who are having irregular bleeding and their lining looks really thin and their FSH is on the lower side? most likely we may not proceed with the biopsy, but I will really strongly ensure that my patients keep a journal of their period so that we can really see how far spaced out they are, what kind of symptoms they're having, and sometimes, but not always, sometimes I do talk about how we could cease the bleeding. And there's a couple ways that we can do that. The first is with a Progestin Releasing Iud. Yes, even if you've had your tubes tied, even if your husband or your partner's had a vasectomy, or even if you're not sexually active. Even though we think about it as a birth control method, it certainly has many other benefits. An IUD, a progestin releasing IUD, is going to release progesterone just to the uterine lining and keep it really thin. That's going to do two things. One, it's going to probably slow down or stop the bleeding, but two, keep that uterus really healthy because the uterus loves the progesterone. And then we feel really comfortable and confident that your uterus is going to stay healthy. In fact, not only are IUDs approved for contraception, but they have been shown to decrease the risk of uterine cancer when used for 5 years. Another thing you can do is a continuous birth control pill or a continuous birth control estrogen progestin, traditionally thought of as birth control. For example, like the NuvaRing. I have some patients who put the NuvaRing in every 3 weeks and never really have a bleeding period, and that works really well for them. And some of my patients take oral micronized natural progesterone, which also helps to keep the uterine lining healthy, and that progesterone kind of helps to stabilize that uterine lining. So it kind of is doing two things. If you do have a polyp or a fibroid, certainly a consultation with a surgeon for a removal is also not a bad idea, especially if these are affecting your quality of life so much. And then again, knowing you have endometriosis or adenomyosis may prompt you to also see a specialist. Whew, so those are some of the main reasons that your doctor will order an ultrasound, particularly at menopause and at midlife. Now, I also kind of threw in there polycystic ovarian syndrome and getting an ultrasound for that. And that's really just going to help overall be diagnostic and certainly monitoring you for a long-standing polycystic ovarian syndrome and watching you into your 30s, 40s, 50s, and 60s is really helpful. So if that cinches the diagnosis, that again is really helpful. So I hope this video helped to break down why your doctor might order an ultrasound for you at midlife, at perimenopause, or even at menopause. Why some women qualify for an endometrial biopsy, and the reason we want to do that is to make sure you don't have any types of precancerous cells in that thickened layer of your uterus, and also what you can do about some of that irregular bleeding patterns or ways to keep your progesterone healthy, i.e. your uterus healthy, i.e. give it progesterone. I may have just messed that up, but I'm hoping that you get the point. Thank you guys so much for listening to my videos and for watching me here over on YouTube. I love your suggestions for videos because I really want to know what you want to know. That's going to help me make the best type of content for you. I think all 1,483 of you who are following and subscribed to my channel, if you're not, please do. It actually really helps more women see this, and that means YouTube will push it out to more women who this could really help them, and that's really helpful for me so that I can carve out more time to make these kinds of videos for you. Again, if you want to follow me on Instagram, I'm at hormone.health.doc, and you can also check out my website, heatherhirschmd.com. Check the links in the description bar below for a ton of other information and links to some of my most popular videos. Thank you guys so much, and I'll see you again next video. Bye!